This video made possible by Killer Visual Strategies. Visit killervisualstrategies.com.
I know this morning we've talked a lot about gene editing. We've talked a lot about advanced technology. Now we're going to talk about being a patient. Everyone in here ever been a patient? No, wow, healthy crew we have. So actually, although we've gone through everybody's name and we know why we're here, Gene, I was hoping you could actually fill out some more information for me that we could fax to our home office.
I'd love to put my information in that form again for you.
Right. We like to keep our clipboards working. So we're actually going to talk about the experience of healthcare today. And really, when you think about being a patient, your experience as a patient starts from the moment you try to schedule an appointment to the time you get a bill. And somewhere in the middle of all of that, you actually get the care you were seeking. So there's a lot of processes and workarounds and administrative burden that is hoisted on you as a patient, whether you know it or not. And really what's happening as a patient, one could say, is that the experience is designed around the requirements of the system rather than the requirements of the patient. So we have some leaders in here who are rethinking what it means to be a patient and to manage the administrative and operational requirements of the healthcare system. So we're fortunate to have this crew with us, and we're going to have a robust conversation about it. So Neil, let's start off with you. How big is this problem? We all know that healthcare has a bad rap for being inefficient, a lot of waste. We as patients have experienced that in some way, shape, or form. Can you kind of quantify this problem for us and give us some insight?
So there was originally a publication that McKinsey put out in 2010 that had labeled the challenge as a $400 billion problem. I think more recently, and it actually came out this week, the New England Journal of Medicine looked through the entire healthcare ecosystem and essentially said 1 out of every $4 that goes into healthcare is what they would define more broadly through a literature review as waste. So 750 to 935 billion is the number that they put out. And when you start to look at the categories that they list, the first one is actually billing and the complexity in the administrative process at about 250 billion. The second that they would call out is around medication and some of the complexity around that pricing and delivery. And then the third is actually more around prevention and engaging patients, and that is $100 billion waste in their view. Some of the research that McKinsey has done has focused more on this question of productivity. And in particular, what we've looked at, and this was 2001 to 2016 as a time frame, was how healthcare was different than the rest of the economy. So the rest of the economy grew at about 1.9% if you're looking at sort of total inflation spending. Healthcare was 3.3% in that period. When you dive into productivity, you can look at it through labor, capital, and then multi-factor productivity, really the intersection of labor and capital. In healthcare, essentially all of the growth was driven through labor. There was an incremental contribution through capital, but what we actually saw was negative multi-factor productivity. So the intersection between that labor and those investments in both physical infrastructure and other technology actually had a negative impact on productivity. So it was more difficult for caregivers, for patients, for the system more broadly to deliver value. So our approach is looking at that problem where we're investing more but getting less.
Great. And so Mike, as one of the co-founders and chief product officers at Lumedic, can you explain to us how you guys are looking at this, how you're approaching the back office component of this problem?
Yeah, sure. So Lumedic is part of Providence, so we're a Providence-owned company. We are very focused in the billing and administrative challenge that Neil pointed out. I promised Laura I wouldn't talk about blockchain or smart contracts
Just lightly.
too deeply. But at a high level, we are on the surface, we look at the patient experience around healthcare, and a lot of what's behind the scenes is the rev cycle, and patients predominantly do not know what the rev cycle is, nor should they. But under the surface of what we have in mobile apps and our patient experience is this entire world of administrative challenge that exists, and the complexities of effectively trying to figure out where to route bills to, who's going to pay the bill, and how to. We do that in effectively one of the most inefficient ways possible today. We still have faxing, we have screen scraping, we have technologies today that, quite honestly, are very, very ancient. So we're looking at how can you apply to that layer below the surface of administrative burden things like smart contracts, where we can codify the rules that govern a lot of these relationships between payers and providers and patients in a way that we can create a network of automation that then allows us to better interact between the different parties involved in healthcare. So we think that if you can address that area from the inside out with a large health system like Providence, then you can actually create a platform to go drive comprehensive change from a patient experience standpoint.
Great. So Jean, when you guys think about applying technology to kind of a big problem like this, what are some of the components that you think about, whether it be sort of philosophically or sort of requirement-wise in doing this?
Sure. I think, I heard a little bit of the last talk, and there was some good discussion around, some of the technical complexity, and I think we're all like really familiar with the technical complexity of making this data liquid and making it accessible for analysis. So I would actually choose to answer the question a little bit differently. I think, a huge focus for us as we're working with partners to actually help kind of move healthcare forward from a technology perspective is thinking deeply about the more ethical aspects of what we're trying to do, and really considering how we actually still keep the provider in control of the data. We'll keep the person in control through principles around transparency, through principles around actually understanding, how things are actually calculated when we think about applying AI. And so these are deep conversations that we've certainly had with Providence, and conversations we've had with a number of partners about how do we actually make this big leap forward that we know is right there, is right on the cusp, but do it in a way that people are comfortable with. It respects them, respects privacy and security and all those basics, and supports them as opposed to just, does the work for them.
Sara, I know that Providence has made a lot of investments in this area and is looking at this from a broad lens. Could you share a little bit about some of the investments and how they're looking at innovation across the system, and maybe even giving a little bit of background on how large the system, quite frankly, is?
Sure. So for folks who aren't familiar with Providence, and a lot of folks in Seattle may not be because our local affiliate is Swedish, Providence is a massive health system that covers 8 states. So we have 51 hospitals, almost 1,000 ambulatory sites. We have a health plan, we have a high school. So the scope and the scale of Providence is really only matched by a couple other health systems out there. I'll put it that way. And so we benefit from that in that we've been able to make significant investments in digital innovation. And the reason I call out digital innovation versus innovation sort of more generally is that we don't actually think that we have a monopoly on innovation from our group's standpoint within Providence. There are other teams like the Lumedic team that are doing a tremendous amount of innovation on the rev cycle side of things. We're doing innovation as it relates to specifically the way in which we get our customers or our patients kind of engaged with us online. That's how we think about innovation. And that's sort of the ultimate vision, is that our customers are, in fact, move them from offline and disengaged in this like fax and telephone world to online and engaged. And we're doing that in a number of different ways, through investments through a venture fund that we've made 17 investments in healthcare IT, tech-enabled service, and digital health companies, as well as through an actual product development organization that is building technology similar to what the Lumedic team is doing, but with sort of around some specific verticals with respect to access and convenience, driving access and convenience, simplifying the care experience, and then focusing in on a couple other verticals like behavioral health and supporting our poor and vulnerable populations where we think digital can have true power.
Great. And let's talk a little bit about engagement. Let's talk about healthcare professional and caregiver provider engagement, and then we'll talk about patient engagement, right? Because we've all heard about, being in healthcare now as a professional is a difficult. One doesn't like the inefficiencies as well, right? And so this is for any of you, how do you guys think about engaging caregivers, healthcare staff, operations to really be part of the solution. That was not a
I can take it. So while we're focused a lot on the patient and consumer side of things, we are doing a little bit of work around sort of generalized AI models, actually, and everyone's talking about AI these days, so I won't jargon it up too much, but looking at how we can actually create virtual assistants in the clinic setting so that like the previous speaker that was up here was talking a lot about meaningful use and all of the sort of technology burden that we placed on our providers throughout the high-tech era. Looking at pre-visit prep, in-visit documentation, and post-visit closeout using technology so that the visit, our providers have an agenda going into it. It's all set for them. They only really have to review as opposed to do data entry, and then and there's that creates that continuity of care. So I think that what we're trying to do is sort of automate take the 4 Ds, and in our case it would be really the dull stuff that we're trying to automate for our providers with respect to the in-clinic experience.
Yeah, and we talk about a pyramid. So for one of our projects called Empower MD, which is an ambient intelligence product that we've been working on, we talk about a pyramid where we're really trying to go after that base that is low value add, that shouldn't take the provider's time, terrible use of her or his time, and really focus instead on letting that person focus on the tip of the pyramid where they can use what humans are great at, right? Without, applying their experience and judgment, decision making, those types of things, and really kind of, work out of the system that huge base that we've only expanded over time.
Yep. I think the only thing that I would add is for many systems, it becomes a question of how do you ensure that everyone is working at top of license or at the appropriate skill mix, and then have that skill mix actually from a labor standpoint in order to ensure that people are having the most effective conversations that they can. And having technology to enable that point in time conversation and having the right information, but also having a relevant person there for the patient so that the conversation they're having is the right one. So I think 2 sides of the challenge.
That's great.
I'd also say, like for us, and we sit with caregivers in Providence in the rev cycle side. I mean, so there's clinical focused operations, and then in rev cycle, it's very administrative focused. There are central access teams in Portland, for example, and one of the areas we're looking today around smart contracts is prior authorization. There's a step today in prior authorization where we have work queues of scheduled procedures that are in the next 14 days coming in for care, and we have people that are caregivers at Providence that look at a list of 5 or 6 different CPT codes and are doing a Control F in a PDF document to go find all of those 5 CPT codes. And whether those CPT codes exist or do not exist in that document, that determines whether or not they need prior auth. That process should not have to happen from a manual standpoint, right? So I said when we sit and embrace caregivers around what could help make those jobs more enjoyable and more automated, that is a very welcome change that we're finding, and we get that by sitting and talking with the caregivers. And so that's, again, a big benefit we have with Providence as a health system to drive innovation more broadly is you have so much of that at your disposal around being able to go learn from what exactly those kind of on-the-ground challenges are. So that's one specifically where I know that everyone's very open-armed around just being able to improve that process because it delays care for patients and it is a burden on the system.
And I would add to Mike's point, which is both the Digital Innovation Group and LouMedic, we benefit greatly from being within a health system. There are certainly structural challenges and systemic challenges to operating within a health system. Health systems are not necessarily innovation friendly, and for good reason in many cases because patient safety is a major issue and a major concern for everybody. But we can sit side by side with providers and patients in a way that it can be very difficult to break into that from the outside. And so we're kind of uniquely positioned from an innovation standpoint to really understand the problems well, to match those problems with sort of requirements around how we can solve them, and then take that and match it to technology that we either develop or bring from the outside in a really meaningful way, as opposed to just sort of in a check the boxes kind of way.
Yeah, you own the ecosystem ultimately. Let's talk about patients. I've been in healthcare for 25 years. I've worked on a lot of different products that went out of style, and 1999 or now back in style. There's so much technology and there's so much innovation. I'm curious, like, is now the time? Is there a real change afoot with all these new technologies out there? That's kind of the first part of the question. The second part of the question is, how do we focus on adoption from patients and really make sure that they're engaged in the solution? Jean, do you have, not to put you on the spot?
Yeah. Yeah, I think I'm thinking about it kind of as a patient. I have a daughter who is full care, if anyone knows what that means. So we're a high consumer of healthcare and manage 30-some provider relationships around her care. We're the only quarterback. And so I think the thing that, for us to even kind of like work through that and understand what to prioritize on a day-to-day basis, it needs to return kind of immediate value to us as patients, right? To her as a patient. And I need to be able to see that and understand that in an easy way, right? Because I can't go necessarily read all the PubMed articles, although I might decide to do that. It's just in my field. But it needs to be something that is accessible to me and accessible to the patient. If I want to put my DNA, for example, into something that, into a system, I need to get back information that is immediately valuable, right? There needs to be kind of a give and take. So I think it's not just that now's the time. I think it's always been the time. It will always continue to be the time. There'll always be more that we can do. Right. Just digitizing our healthcare information, I think, is already a huge accomplishment. Like, we should understand how meaningful that is. And start to work on, like, okay, now what can we do? And very simple scenarios and examples, like you called out. That's a really simple example, right? We don't need AI for that. But there's so much low-hanging fruit that we can go after and actually start to move the needle on the patient and caregiver experience.
Great. Other thoughts about how to engage patients? You have a wide range of use cases for who your audience is. How do you prioritize? How do you think about it?
So you had actually called out, the patient experience starts with the moment you try to book an appointment, and it ends with, whether it ends after the appointment or your ongoing kind of engagement. Everyone's different. I actually think that it starts much earlier than the appointment, right? It starts with Google and WebMD and whatever sort of information retrieval that we're kind of looking for, and as consumers of information and consumers of healthcare services. So we've focused a lot on sort of three big, maybe I would say, chunks of the journey. One is the discovery phase, and this is just, I'm out there, I need information. Maybe I'm not, maybe I have a specific condition, maybe I don't, it's irrelevant, but there's discovery. Then there's the actual transactional piece. That's the booking an appointment, that's the registration process, check-in, all the payment, the actual visit itself. And of course, these can occur over different modalities. They don't all have to be in person, they can be virtual. And then there's the engagement on the back end. So there's sort of discovery, transaction, and engagement. And there's opportunities within each one where we can earn trust, where we can remove friction, where we can get a lot, sort of make the experience so much better for the patient, and that's how we think about it. So there's a lot of underlying technology there that can improve continuity, it can improve information flow, and all sorts of other things. I don't know if you have anything to add from your perspective.
Yeah, I agree, and I think right now, I think that perspective is, from a patient standpoint, still fairly fragmented, right? If we're talking about kind of that end-to-end view of a patient episode of care. We start by looking at kind of individual patient journeys as well, and for us, we predominantly just feel like as patients, we at LouMedic have all felt like we've just not always had an advocate, or not even really knowing who to go ask for to understand transparency, understand financial costs, understand the burden, even understanding things like deductibles and HSAs, right? So there's a whole area of financial information today in healthcare that as consumers and as patients, to your point, depending on when you decide to interject technologies that go solve the problem, there's a whole layer of just across that journey understanding what the financial implications are going to be. Because right now, whether you're Googling for information or whether you're actually calling your doctor, oftentimes no single source has the right comprehensive answer for you. So it's actually a hard problem. I think for us, we are looking at how do you actually go create, whether it's supporting some of the financial counseling work that happens, in some cases bedside, where it's understanding what exactly are my out-of-pocket costs going to be. In a lot of cases, many patients just don't know the answer to that. And so in some cases, it's can you equip, even at that point, you're at a different point in the journey, but you're equipping caregivers with the right tools and digital tools to help patients understand those decisions. So don't know exactly where I went there, but.
That's great.
Well,
That's great.
I think the one thing I would add is, I think these are many use case narratives. The other that I think everyone's looked at is the different patient archetypes
Right.
and how you'd address them, where if you look at Medicare as a program example, for every incremental chronic condition that a patient has, the spend, so per member per year, essentially doubles. And so you have plenty of players that are coming into the space saying, someone who has an average per year spend, or a patient archetype with an average 40,000, 50,000, 60,000 per year spend, let me design solutions for that one, because there's a clear economic model. So it's a combination, I think, of the use cases and then the patient archetypes for a variety of innovative companies, standalone players, to try and figure out something at the nexus of those two.
Doesn't sound complicated. Thinking about consumerism in healthcare and just the advent of the technology that we're talking about, how do you guys think that our role as a patient might change or evolve, or our relationship with a healthcare system or a provider may evolve?
Well, so first of all, I think it has to evolve, right? Because, even earlier today, I know there's been conversations around transparency. That's been a very hot topic for a long time now around healthcare. Our interesting perspective today that's happening more broadly is, if we look at the trends in healthcare today and consumer spending as patients, we have the advent of high deductible health plans. We have the stat that I think it's by 2022, forecast that patients will be the third largest payer in the country. And in that case, you now have patients that are shouldering a lot of the burden and the payment transactions happening in healthcare, yet the revenue cycle was not built for patients. The rev cycle, that again, patients don't know that it exists, was built for claims processing and back and forth transactions with health plans. So we've got to go figure out a way that patients are more central to things like the rev cycle, which is what we're focusing on the back office side, because our opinion is that if you don't actually embrace patients in things like the revenue cycle and all these digital events that happen throughout that episode of care, then we're not going to be able to actually provide the right level of patient engagement. So how that evolves, I think this is why I think we're excited about being part of Providence to drive some of this, but it's going to take a lot of effort.
Other thoughts as you kind of implement or explore other types of technology across the system in terms of how consumers might look at healthcare?
I'll answer. I kind of added myself, my archetype. Is that what you said? I kind of added myself as we're a high consumer healthcare archetype. I spent the entire summer trying to get my daughter's only walker repaired because of the back and forth between what was needed by the insurance company for a repair and then the DME vendor. And so I think it's actually going to be repaired tomorrow now, and it's been with the DME since June. And so I think one of the reasons that there are so many passionate people involved in this problem, and there's such a feeling of a mandate, I think is because there is so much human impact. And I just gave one example, like there's so many different examples, and it happens in every system. It happens across, all of the major, entities. It's not a provider problem, it's not a payer problem, it's across everything. And so because of that human impact, I think there's a push and a desire for more, right? And so I should be able to go in. This morning before coming over, I went in and I had to move an appointment, and I had to go and make sure that the vendor that's fixing my daughter's walker actually knew that they really did have the equipment, and they didn't actually need us to come over there tomorrow for the repair in person because they have the equipment. And so, every single day it's like that, and there's such a human cost, and that will always come out of the time with the patient, or it will come out of some other very valuable resource for the patient. So I think that drives all of us to want to make things better and improve the outcomes and the experience kind of across the board.
Your story is just so powerful because it's really unacceptable that's the point at which we are, right? And our bar is very low for healthcare, and that's not going to Mike's point, that's not going to be the case in 5 years. I had a baby a year ago, and at every point in the journey, something went wrong, meaning like the prior authorization for genetic testing didn't go through, and I ended up having to call back and forth, and who knew, like nobody knew who was the right person to get this resolved, right? And that was just one example. There was, at every point in the journey, there was some misinformation, or I had to quarterback it myself. And I think as patients and consumers, we're going to eventually, in the not too distant future, start making actual decisions and based on how bad or good these experiences are. And one of the reasons I think we're going to be more activated is that we're all locked into sort of consumer ecosystems that work for us and technology ecosystems that work for us. And those technology ecosystems like the Amazon, Apple, Google, the consumer-facing technology ecosystems are going to shift us to what works over time. And in addition to the fact that we're more and more on the hook for the cost, and it'll get worse if there's a recession, that will, I think we're sort of reaching that inflection point where demand is actually going to move.
Yeah, I mean, as a patient, you pick your provider based on the care delivered, not the overall experience wrapped around it. What I hear you saying is that will shift over time, and is starting to shift over time, because it has to be about the whole experience. It can't just be, it was terrible, and it was terrible until the moment I saw my provider, and then it was terrible from the moment I left. And so that's going to start shifting. We wanted to have this conversation because it's really interesting, and Jean, I agree, your story is really pivotal, I think, for this conversation, because we're talking about splitting genes and re-engineering T cells, which is amazing and fabulous, and it needs to happen for the advancement of medical care. And you can do all that, and that will help people, and obviously the value is tremendous. But I think what you guys have done well is sort of bring back that there are patients that run through these lanes and these hamster wheels throughout all these health systems that have different needs and requirements and different archetypes and all of that. And to address it is complex, but certainly it needs to be done. Neil, have you guys done any research in terms of sort of the provider component and provider attachment, and how patients look at the overall experience kind of with their provider kind of sitting in the middle of it all?
I mean, the experience obviously matters. When you look at essentially patient satisfaction, there's a variety of variables in the CMS studies. The ones that are most, I think, compelling are the physician communication and nurse communication measures. So going back to Jean's earlier point, it is really that conversation that people are having at the bedside. I think the other point, just linking it to the prior question, is almost the who is your provider and who are you going to be, let's say, the gateway to the rest of the system. So Jean is effectively the quarterback among 30 providers, but there are plenty of others who will look at the diversity of potential sites of care, whether that's telehealth, minute clinics, urgent care, the ED, and then freestanding EDs. So the number of access points has proliferated significantly. If we roll this story back 50 years, you would have had a primary care physician who would be the point, or the emergency department. Now what we're actually asking patients to do is almost self-triage. So you have more conditions and the delivery system has more options. Actually doing that matching is one of the more complicated engagement problems we will have moving forward.
Right. Yeah, one of my first companies I worked for back in the day was a disease and demand management company, which basically was a nurse line, which we all have had at some point in time. And the options were, go to the emergency room or call your doctor. I mean, that was it. And now there are many more options to deal with. Let's talk about payers a little bit. We haven't really talked that much about them. They're obviously a crucial component to this puzzle. What's their role in all of this? How do they participate in helping solve this problem? Be nice, because there is a Regent's logo right over your heads.
Yeah, I can say from our standpoint, again, so Lumedic is interesting in that we are really looking at establishing smart contracts that sit at the intersection of payer and provider relationships. So payers are absolutely in focus for us as far as our conversations. We are actively working with Regents and some other companies also around how do we look at driving some innovation in the space. I think traditionally there's been getting both parties to the table in a way that is, I'd say, amiable to both sides has been challenging for a number of reasons. For us, we found a lot of, I would say, we've been able to get payers, like Reasons, for example, coming to the table where we're talking about shared experiences around the member and the patient, right? So the commonality, interestingly enough, like the only kind of guaranteed constant between an episode of care is the patient, not the health system, not the insurance company. And so the patient is the constant. When we put things in terms of the member experience or the patient experience, that's when we've been able to actually attract both sides to come to the table. Prior authorization is one of those examples, right? I mean, we actually share, when we share with payers the actual impact that it's having workflow-wise on the provider and caregiver side, and also what that impact ends up being as far as delayed care days for patients, that matters because as whether they're benefits administrators for self-insured employers or they're the direct commercial payers, everybody cares about the experience of the patient or the member. So for us, it kind of reiterates the impact that patients will have going forward, and it has to be all about driving value back to the consumer in this case. And so just that conversation's been, I think, evolving for sure.
Great.
We see, we talk about the 6 Ps, right? With the patient, of course, first, and providers, pharma, payers, of course, is a very important P. Mm-hmm. And we see innovation absolutely across every one of the 6 Ps, the final one being policymakers. Mm-hmm. I mean, there's a push and there's innovation at every single level. And the payers are absolutely reconsidering what they bring to the table more than the kind of a claims processor. How do they actually affect the outcomes? How do they insert even additional care at the right point in time so that the eventual outcome is better? And I think thinking through that end to end then brings new demands on the system around where data needs to be, how data needs to be accessible, and those things. But we absolutely are having those conversations with payers the same as we are having with providers and pharma and other players in the industry.
Great. So we are close to the end, so we're just going to do a lightning round. And I promise it will be the question that I told you I was going to ask. So how will we know you guys are successful? Mike, we'll start with you.
Sure. So we'll be successful when we hear from patients that we've eliminated confusion around patient financial liability. So understanding their bills.
Great. Sara?
I'm going to take it easy on myself and say we'll know we've been successful when we've fulfilled Providence's promise, which is know me, care for me, ease my way. I think that sums it up perfectly.
Great.
I'll say we'll know we're successful when healthcare looks like the rest of the economy. A dollar you put in gets similar productivity and results to what you'd expect wherever that dollar goes.
Great.
I don't think I can top that one, but our focus, we think we're successful when innovation can happen on top of us as a technology platform by all players. And so I think it's going to be a process over time, right, where we see new innovation, new successes happen. It's not going to be an end point.
Great, great. Thank you all for your time. We're not going to take questions, but you're welcome to approach any of these people once they leave the stage. So thanks for your time.